Second talk, very pleased to have down from the frozen north, Dr. Janet Pope, who's going to talk to us about rheumatoid arthritis, myth or fact. And I think, what did you want to call this? Lies my mentor told me. So yeah, we'll get that plug in there for you. Welcome, Janet.
Great, thank you so much, Artie. And thanks, Jack. And some of what I'm going to do today, there is no right answer. I still want you to vote, number one. And number two, some of it will tie in with what other speakers have talked about today, at least in rheumatoid arthritis. So these are my disclosures. I'm open to get more disclosures. Because I tweet, I think everyone thinks my patients are under really poor control, but we actually can get access to effective agents in Canada, and I can use them. But we see the many faces of rheumatoid arthritis in the many hands and chest x-rays, etc. And many of our patients now look like normal joints when we look at their hands, which is amazing. So I want to talk about some clinical assessments in rheumatoid arthritis briefly, a bit of extra-articular manifestations, an update on new treatment, some future concepts, but I mostly want to challenge your assumptions in RA from pre-RA up to and including treatment with drugs such as methotrexate. So when we are thinking in the paradigm of methotrexate, many of you have thought about, okay, it's starting smoking, increasing the risk. We have IgA going up in areas like the lung, other mucosa that are first-line defense against bacteria and viruses. And then we seem to get something, maybe a second hit, that will then cause rheumatoid arthritis. And all this is fine and well, and it probably makes a lot of sense. And it's difficult when we see a patient to know where they are on the spectrum if we haven't made a diagnosis or we're not there yet. We also know the cytokines can really vary over early or pre-RA, early RA, and then established. And we can also get a lot of epitope spreading. So when you have no RA 10 years prior, and maybe you're making an antibody, it might be very monoclonal and not very large in dilution, and then it can go polyclonal, more targets over time. And again, not necessarily in everybody. The other thing that's really important as sort of a myth is, many of us my age, even younger, were taught that RA is a disease of childbearing women. And I guess it's true in some countries you can still bear a child when you're 70 years old, but not usually. You can, but not usually. But RA is increasing in one sector of the population, doubling to tripling, and that is the elderly. And by elderly, I mean really over the age of 75. The incidence and prevalence is doubling there. You understand why the prevalence might be going up, because patients are living longer, but the incidence is going up as well. So that's a lie, I've been told. But it's maybe because things have changed. The other thing is the elderly are often not offered appropriate treatment, and it might be for many reasons. It might be that we think prednisone is easier access in many countries, so the poor person's advanced therapy, so to speak, poor meaning harder to get access, is instead of biological drugs or targeted synthetic drugs, which might be controversial as you have more comorbidities in older age. We tend to probably give them more glucocorticoids. But in many studies, there are data that it's safe to use advanced therapies in the elderly with some of the caveats. But they also don't do as well, and they don't do as well because they have a lot of comorbidities. And for every comorbidity you have, the chance of going into remission goes down a little bit. And the elderly and the middle-aged have more comorbidities than the young people. The elderly often onset seronegative, more acute onset, so you think you could get them into remission more, but they start at a higher DAS, so the delta DAS is about the same as the younger people, but if you start higher, you end at a higher level, so a bit less remission. So there's a lot we know in rheumatoid arthritis. I think we all know there is a window of opportunity, but it's never too late to unscrew that window and open it up, so we can treat people at any stage. We know about antibody spreading, epitope spreading. We know that it's safer to treat than not to treat, even though we've had a lot of lectures today about benefit and risk of our drugs. We know that the outcome measurements in RA are sensitive to change, that they have some degree of face validity, and I might question that later. And we know some of the predictors of poor response. more established disease, longer disease duration, more comorbidities, probably elderly, like I said. But there's a lot we don't know. You heard from Dr. Dean already. We don't know who will progress from pre-RA to RA, and we don't even know what pre-RA is. It's got no standardized definition. We don't know why patients flare or become recalcitrant to treatment. Sometimes it's they're not taking their drugs, and Joel would know that if he did a level to tell us that they're not taking their methotrexate and then they flare. We don't know what order to use drugs, and that's kind of crazy. That would never happen in breast cancer or melanoma now. There would be a sequence and as you got drug resistance over time, there would be a repeat biopsy and a new sequence. So we really don't know that. And then we don't really know how to treat extraarticular manifestations. There was some buzz today that maybe nodules are less in certain drugs, such as JAK inhibitors. We were talking about that at one of the breaks, and nodules less on leflunomide and possibly less on rituximab and hydroxychloroquine, but maybe more in a way on some patients with methotrexate. So the first myth is we can prevent RA. So we're certainly not ready to screen the asymptomatic population to give like a vaccine, not that we have one yet, but there is a lot of work going on that. So a myth or a truism is that ACPA and RF can precede RA, and there were two big studies. One was bank sera from people in the forces, so probably with some degree of not really informed consent. Their data were banked and then looked at later. And you can see that the levels rise just around the time of diagnosis, but you can go back 5, 10, even in some studies 12 to 15 years. So the first myth is that RA development should have ACPA years before. So that is true. I just showed you some data for that. But many patients that we classify in early RA do not have ACPA, and they don't have rheumatoid factor. And in rheumatoid arthritis, there is certainly about 40% of patients who are double negative. And we really think that we're not misclassifying from pseudogout or psoriatic arthritis. It's true in multiple cohorts, including our Canadian cohort, but true in Leiden, true in Paul Emery's group and elsewhere. So these are some of our data showing that double seropositivity in early rheumatoid arthritis, less than 1 year from first fixed joint swelling, about 2/3 are positive for one or the other, about 60% positive on either one. So there is some overlap between them. But conversely, that means at least 1/3 of my patients do not have this, at least the epitopes that we identify as ACPA or RF, that they don't have that at the beginning. So just keep that in mind when we always say, oh, your autoimmunity predates. It probably does, but there's probably other antibodies that we don't know anything much about. So this is our first question I'm going to ask you, and you can sort of start voting at any time. So lifestyle factors increase the risk of RA except, so what is not associated? Smoking, normal BMI, silica dust, positive family history of RA. So I will let you guys vote here, and you're all very, very smart, or most of you. 91 or 2% of you are very, very smart. Well, maybe a bit less now. It's up to 95 because I gave a hint. And this isn't always true, but this is what I'm going to tell you, but then I'm going to go into some myths. So thank you for voting so that I can prove all of us wrong. So this was a wonderful study looking from the Nurses' Health study, looking at lifestyle associations explaining your risk of rheumatoid arthritis. And it was kind of cool because it was a protective dose response. The more good lifestyle stuff you had, and by the way, in this study, alcohol is a good lifestyle in moderation, but not in heavy alcohol use. So the Nurses' Health study, 120,000 women followed prospectively for many, many years now, and there's the two studies, and really looking that if you had one protective factor, you decrease the chance of rheumatoid arthritis, and a dose response the more you had. And it was exercise, the best quartile of healthy anti-inflammatory kind of Mediterranean diet, et cetera, normal body weight. So you guessed right that high BMI is a risk. Okay, another myth though is smoking is a major risk factor for RA. It is a risk factor and our patients shouldn't smoke. You can attenuate benefit with treatment, but it's interesting because if you have the shared epitope, so that's your HLA-DR4, very specific ones that are increasing the association of rheumatoid arthritis. If you are double epitope and you smoke, that's the blue there, your risk goes way, way up. But if you are smoking and you don't have the epitope, I think that risk is pretty darn bland. So I'm not saying smoking's good for you. I'm saying our patients should be encouraged not to smoke, and smoking will increase RA, but it's in the HLA-DR4 double epitope population. So just think it's true, but it's a lie I've been told. The other thing is high BMI is increasing the risk of RA. This is again from the Nurses' Health Study. Only if you are ACPA positive. That's the big risk there. You see, it's a 2x2 table. So if you're ACPA positive and high BMI, you have a really high risk. Whereas if you have a high BMI and you're ACPA negative, the risk isn't really there. So the next guess we're going to have is this is true or false, and you can vote at any time. So we should use hydroxychloroquine in someone with arthralgias and positive ACPA to prevent the onset of RA, and Kevin's not allowed to vote. So we'll see who might have listened this morning. So can we stop RA? And you know, before the important trial, I would have thought it was a great idea. And there's a lot of benefits to hydroxychloroquine. Not treating your COVID though. Okay, so we have almost everyone getting this right, and Kevin did present this morning. So the STOP RA, unfortunately, although a little bit underpowered, you can see there's nothing going on there. This is the rate of at-risk patients getting developing classification criteria for rheumatoid arthritis, very same on placebo and hydroxychloroquine. There are some drugs that can be helpful that Kevin reviewed, but they wouldn't be ready for prime time. Abatacept, rituximab, only giving it once will delay the onset for a bit. Methotrexate, but when we stop it, the attenuation of delayed response goes down. Okay, and here's the abatacept looking over time. 6 months of abatacept in the at-risk population, but they were maybe they were more than at risk because they were ACPA positive and they were MRI positive for synovitis, at least somewhere. So maybe they actually had synovitis because they had it on imaging. But for 6 months, you can see the orange is abatacept. The placebo is the darker color there, and you can see that you're really not getting patients getting RA too much at all on abatacept. And even when you stop treatment after 6 months and follow for another year, you can see that the benefit is starting to wane, but you were still better off having 6 months of treatment. Now, if abatacept was inexpensive like hydroxychloroquine, I think we would be all over this. But again, not ready for prime time, not approved this way. Now, this is going to be an A, B, or C, so you're going to vote now because I did say I'd talk about outcome measurements with some degree of face validity. So which is worse? A, the patient's CDI 19, B, their CDI is 19, and C, the answer is it depends. So the first patient, A, has 2 swollen, 2 tender, but MD global is 7. That's pretty high. Patient global 7. Second patient, 5 swollen joints, 2 tender, MD global is 4. Patient global is 8. So which is worse, A, B, or C? So we'll have you vote. Okay, so B, that's really interesting. We'll see what happens with people. There's more than one right answer here. I'll just give you that. There is not a right answer. I think it really depends. Okay, so nobody says A, but we have B where they've got, I think the MD global gets a bit higher. I think that I can't remember which order I gave them to you in, but one has more swollen joints, tender are about the same, and MD global is different. Okay, so I think it depends. So it is a myth. So another lie I've been told is a swollen joint is a swollen joint. Well, of course it is. But I think you might beg to differ there. You can see the IP of the thumb, the second MCP, the second PIP. By the way, she has a second DIP too, but I can't help that. This lady does have RA and occasionally DIPs are involved. But I would call her 3 joints there on that hand. Look at the one joint here though. I don't know. I would say the second person with a giant shoulder and an arm attached is probably far worse off. The other thing is, if you do a 28 joint count, what about the ankles and the feet? So I think knowing a score, you have to look at the components. It's not an HbA1c equivalent, unfortunately, in rheumatology. So the next myth, I mean, if you saw my Twitter page, you would think that I can't get anyone in remission, but I don't take their pictures. I honestly don't take their pictures. Lots of people are in remission. But there's a myth we can get most RA patients into sustained remission. We're to treat to a target of low disease activity, Boolean remission, the clinical definition, a low DAS, a low CDI, a low SDI. So in early rheumatoid arthritis, these are data from our CATCH cohort that we do need to publish someday, but what we showed was that DAS remission, or DAS low disease activity, and we went up every a couple years that our cohort's been going on, looking at the new patients. So whether you were diagnosed and entered 10 years ago, 8 years ago, et cetera, 6 years ago, and you can see that we kept getting more and more people into low disease activity or remission, but we're hitting a wall. We're hitting a wall maybe around DAS 70%, 72%. And our cohort, with very little in these data, very little biologic penetration, we have pretty good remission. And I think we know how to count joints in Canada. It's that we don't do anything too fancy usually. We just do a joint count like most people do. But we're hitting a ceiling effect. And some of it might be the scores, the intrinsic problem with having chronic residual pain, fibromyalgic RA, et cetera. And some of it is our drugs, we do hit a wall over time. So these are data showing in our early arthritis cohort that we can get if we look at a very tight definition. So SDI, which is your tender joint count, swollen joint count, MD global, patient global, and a CRP. If we add that and get less than or equal to 3.3, so 0 swollen, 1 tender, a bit of a CRP or a patient global of 1 kind of thing, we got 55% of our patients into that remission, which is virtually true remission, I think, 55% over a year. So that's like pat yourself on the back. I mean, if that was your report card of your kid, 55% you wouldn't be too happy with, by the way. But 55% is the highest we have in the literature to date. But the next year and the year after, we lost some of those remissions. So if we look at the 55%, looking 2 years out, we've lost half of them in remission. And these should be the easiest to treat. This is our window of opportunity. These are literate people who are usually adherent because they agree to do their forms and come into being observed in a study. So these people have probably a leg up on our regular patients because they actually know they're being observed and they want to probably do better. So we can't get people into remission, almost half of them we can't, even in early RA, and then we can't sustain them when we get them there, unfortunately. What about an established RA? An established RA, this is not a tight definition of remission. If you look at SDI as tighter or Boolean, even tighter, but if you look at a DAS less than 2.6, you can get, again, a failing grade of patients in remission in established RA, but it's not very good. So either we have to change our scores, change what we're trying to get to, or be more rational. We need biomarkers and science to tell me what to do and how to keep people well when they are. We also know there's a ceiling effect in treatment. So the ACR or DAS change responses, they look fairly similar between each drug. They're not identical by any means. And within a group of individuals, a patient might respond to everything and another patient might respond to only 2 of 5 options. We just don't know. So there's a ceiling effect. So another myth is that the treatment selection and the order of treatment in RA is rational. I think, again, we have to learn from oncologists that if you have a certain phenotype, you'll get a certain kind of treatment, such as I mentioned earlier, breast cancer. So this is a slide I stole from someone's slide deck. Thank you, whoever's slide deck. I took a picture of it. But anyway, it's showing that there are different sets of people with RA, and the easiest way to look at it as a clinician, not a translational researcher, is that there could be more, but there's about 3 groups of people. They have B cells that look like formed lymph nodes, not so common, but can occur. They have lots of B cells, but not forming lymph nodes, or they're really fibrotic. And the really fibrotic group it's almost, not quite, but almost one-third, one-third, one-third. That fibrotic group is recalcitrant to change. They usually don't get into remission as much. They don't get sustained remission. And I don't have a clue who they are. And none of us really do. But if we did, maybe we'd have a more rational approach on certain groups of drugs in certain patients. So the next myth, and I'm on the EULAR guidelines, so I can say it's a myth. I'm not on the ACR guidelines, but I did review them. So EULAR and ACR guidelines of monotherapy with methotrexate are the best initial treatment. In fairness, EULAR doesn't give monotherapy. They say give glucocorticoids, bridge, and get rid of them if you can, as fast as you can, and use methotrexate in the poor prognosis. And RA guidelines say use methotrexate. Well, we just heard Dr. Kremer say that he loves to use hydroxychloroquine with methotrexate. And I think I was one of maybe 2 people that said, oh, I love triple therapy despite the sulfasalazine. So it is true that if we want to fail, we should start with methotrexate monotherapy. So 70% of the time, remission is not achieved in methotrexate monotherapy and poor prognosis active early RA. 70% of the time, you will fail if we're going to target remission. And that's true on all those trials I put there, because when I first used to say this statement, everyone said, you're just making it up. So I actually had to get references for what I'm not making up. But if we use combination therapy, whether it was combination with a TS DMARD, a CS DMARD, a bio DMARD, 2 drugs are better than 1 in early RA, and I'm talking about poor prognosis, seropositive or erosions, lots of swollen joints. So it's really interesting that we have guidelines that say you should fail and then move on. I guess you could say the other side is it's an inexpensive drug and 1/3 of the time you'll pass, but I'd rather pass 2/3 of the time or frankly 3/3 of the time. So let's do our next question, and Dr. Kremer might agree with this or not. So this is another vote, true or false. Folic acid, folate supplementation reduces cytopenias in RA patients using methotrexate. So let's vote on that. So it's either true or false, and I hope you get the option of true or false on this. And you might not get the option, no option maybe. I'm watching my time. Oh, the Wi-Fi is off. Okay, let's do a vote then, but that means we don't have, okay. So who says folic acid supplementation, however you love to give it, I don't care how you give it, but who says that it reduces cytopenias in RA using methotrexate? So we have some trues, and who says false? And who says I couldn't care less, I use it anyway? I can say that last one. Okay, let's do one more poll, then I'll give you some answers. Folic acid supplementation should be co-prescribed with methotrexate and RA. I didn't care about the day, but should be. Who says true? And who says false? And who says I don't know? Okay, so I wonder if some of the data of methotrexate, although in the days gone by it was lower dosing, but I wonder if some of the data was before folic acid was in everything we ate and drank in North America. Folic acid is in your kids' Lucky Charms. They are magically delicious, and they actually have folic acid in them. It's in beer, I think, now, so is thiamine. It is in virtually everything because we don't want neural tube defects. And thank you, the online people said should be co-prescribed 95%. So I wanted to do this as a lie, I've been told, and say it really doesn't make much difference if my patients eat. The very elderly, bit of renal impairment, maybe, and the childbearing potential patients, maybe. But I'll tell you, I couldn't really tell you that that's true because there are 2 systematic reviews, and interestingly, there's some good things about folic acid supplementation. So a good thing is it seems to reduce, interestingly, GI side effects. It might or might not reduce other mucosal problems such as having sores in your mouth. There are no data whatsoever that it reduces cytopenias, interestingly, in all those RA trials, 0 data. But interestingly, it might reduce transaminitis. And there is, in one of the systematic reviews, there's 2 out. I'll just give you the reference for the second one while I'm talking. It might increase the durability of use. So that's the main reason why I would use folic acid. I couldn't care less what folic acid, at what dose, and on what day. So Joel, when we talk about this, I don't know if you're going to agree with that or not. Folinic acid is really expensive, far more expensive than it should be. So I don't use that except for to bail people out. Okay, I think, am I over now? Am I on the over side or the under? Okay, I'm good. Okay. Oh man, whoa. Okay, true or false? We don't need to inject swollen joints at the onset of RA. So for those in the room voting, who would vote that that's true? We don't need to inject. Guidelines don't. Okay, we got some. And computers back up. Okay, and false. All right. So I thought I wanted to do this one because I think we underplay this is my opinion, I think we underplay the value of joint injections, particularly in early disease. So 2/3 are saying we don't need to inject, and 1/3 is saying, well, maybe we do, or it's not true. So this is an old study, randomized controlled trial on joint injections in RA trials. You're lucky if you hit 50 people, so this is a normal sized trial in this kind of thing. But it was a nice trial, so I thought I'd bring it up even though it's old data from 2014 in a journal you've never heard of, but it was kind of nice. The patients got methotrexate and sulfasalazine, and half are randomized to inject every swollen joint at onset and half not to inject any joints. So they all got double therapy, and you can see that 3 months after the injections, and you could say, well, the injections are wearing off then. Yeah, so that's probably a good time to look. They're not going to last for 6 months probably, but the mean DAS that started the same went far lower, clinically relevantly lower, like as though this is a very good drug, by the way. The ACR 20, 100% versus 84% in the two groups, so the injections did better. ACR 50 was 3-to-1 getting it, so 60% in the injection group, and ACR 70 was none in the double therapy and 1/3 about in the double therapy plus injections. So because I have done reviews in this area, it has changed my practice into giving injections. So true or false, it is better to give oral or intramuscular glucocorticoids than to inject 6 to 12 joints in active RA. So let's vote on that. True, it's better, it's a lot easier. And I don't know what your fee schedule is, but for us, it's probably not worth our time to inject 6 joints, 6 to 12. But let's say, oh, this is interesting. So we might have again a 70-30 split there, or 2/3, 1/3. So people are saying, yeah, I'd rather just give them an intramuscular, the Medrol pack, or whatever you guys call it here, or giving a short course of oral prednisone. And in Europe, they would certainly give a short course, which becomes a long course of oral prednisolone. So let's just see one more study before we call it quits. So this is a randomized controlled trial, polyarticular inflammatory arthritis. By the way, they were rheumatoid arthritis patients, 69 in the whole, like 2 groups. And you had to have active RA with 6 or more swollen joints, 6 to 12. And you got intra-articular injections on that whole 6 to 12. Or you got, and this is where you might complain about the methodology, you got 120 milligrams of intramuscular Medrol, Solumedrol, Depomedrol. So just if you're going to do a bit of math here, if you're doing big joints, you're getting a lot more glucocorticoids in those joints being injected than one intramuscular. But again, the data are the data. So they had, interestingly, less side effects with intra-articular steroids. Maybe the patients were afraid to complain and never came back, but less side effects. But the intra-articular steroid group, they looked at 1 week. They were better. Twice as many were better, have an ACR 20. They looked at 4 weeks. Again, almost twice as many were better. But they looked at an ACR 50 at 4 weeks as well. And it was a 2-to-1 ratio. And you could say, well, what does it matter? We just heard that maybe methotrexate takes 6 months to be in steady state. But it actually is in steady state. It actually gives effect. Methotrexate does in 2 to 6 weeks. And that's why if you hold it for more than 2 weeks, some people will flare. So you could say, well, why bother? My drugs are going to kick in. But if I were the patient and I had to go to work, I would like you to fix my joints up, because I might buy in falsely that the drugs I start at the same time are actually highly effective, such as the methotrexate. So I do have patients coming back and say, Dr. Pope, you were right. You said I'd be all better the night I took methotrexate. And it's like, I did not say that. I said I'm going to inject every joint, and then you'll be all better, and then methotrexate will kick in. So we just have to think about that. So I think that we have to challenge some beliefs in rheumatoid arthritis treatment, from pre-RA to early RA to established RA. I think we have to challenge our outcome measurement scores, especially when they might, and within an individual, lack face validity. I think we need a better profiling of patients. That's certainly not ready for prime time yet, but we have to learn from the oncologists. There's the AMP group here, and there's the group in UK and multiple areas now in Europe who are doing biopsies of the synovium to try to teach us what might become biomarkers over time more easily available. And then I think there's a large gap. There's a lot of unmet need for our patients, and I haven't even talked about the patients' PROs, et cetera. We have to learn why a patient has a secondary loss of response and what order to use drugs. So with that, I will stop challenging you and call it quits.